we palpate, we push to see if we can feel a defect. There's that old joke, what does it hurt? Right here, doc. Right. Then we stick our finger in it, but there's a reason why we do things like that. Touching patients and palpating, as we describe it, provides information for us. And as I stated, when there is an Achilles tendon injury, when there's a complete rupture, quite often you'll be able to feel a gap there. There may be weakness with plantar flexion. Plantar flexion is when you push your foot down. Well, if the Achilles is ruptured, that's going to be extremely weak. And there also is a increase in passive dorsiflexion, as you can see in this picture here. If a person is face down with their knees planted on the bed or the examination table, you'd expect the heels and the soles of the feet to be equal. But if a person has an Achilles tendon tear, those images or pictures of the soles will not be equal. So increased passive dorsiflexion is what you can see in that particular situation. So after you get a history from the patient, after you do an examination of the patient, the next step is imaging. So there's a few different types of imaging studies that are available when evaluating this type of patient. Number one would be X-ray. Although the X-ray may not show the tendon very well, it can show associated fractures. Remember, the tendon attaches to the bone, so it's always possible that there may be associated fracture. So that's why an X-ray will be done. Another option is an ultrasound. If you do not have MRI readily available in your institution or in your office, an ultrasound may be an option to pick up an Achilles tendon tear. But the gold standard would be an MRI. Very, very good study to identify an Achilles tendon tear.